This case study presents the sudden death of a 55-year-old black woman who had been followed many years in the hypertension clinic. Woke up at various times, had revealed no evidence of renal disease or endocrine abnormalities. On a recent office visit, her blood pressure was measured as 190 over 105. Few months ago, that patient was admitted to the hospital with complaints of shortness of breath. Her records show she had mild ankle edema, bibasilar walls, and hepatomegaly. A chest X-ray showed cardiomegaly and slight arterial enlargement. Her ECG confirmed left ventricular hypertrophy. Laboratory studies suggest light hepatic damage. Her serial cardiac markers were negative for MI, and her significant increase in her serum B1 and creatinine was noted in the last few years. I choose to discuss about the genetic factors of hypertension in African American. This first article is titled A Consideration of Genetic Mechanism Behind the Development of Hypertension in Black. Hypertension is one of the most commonly treated chronic diseases. The pathological distinction of hypertension in Black and other population groups is grounded primarily in genetics. African Americans are more likely to develop complications associated with high blood pressure. These problems include heart disease, kidney failure, and stroke. Although researchers do not have an ultimate answer as to why hypertension is common in African Americans, some believe it may be triggered by genetics factors. According to this article, the characteristic low renin salt-sensitive hypertension of Black is consistent with the kidney reabsorbing additional sodium, which leads to an expanded extracellular fluid volume that becomes the driving force behind the development of what may be a race-specific form of hypertension. This article concludes that in comparison to white or other race, Black appear to have a more expanded plasma volume due to an increased sodium reabsorption by the kidney. This may be what predisposes Black to more severe hypertension. This article reviews gender-specific issues in the presentation, evaluation, and outcome of ischemic heart disease. In reference to the case study of the sudden death of a 55-year-old African American woman, we're trying to determine whether the incidence relates to coronary atherosclerosis, which remains the leading cause of death in many countries. Patients with coronary disease present differently. Some will come with stable or unstable angina, and others with myocardial infarction. All of them can result in sudden death. Several studies have focused on the primary cause of the development of atherosclerotic plaque. In this scenario, a factor that may stimulate plaque growth is hypertension. An understanding of the alteration caused by myocardial ischemia can contribute to the reduction, if not also the prevention of permanent myocardial damage. The study outlined three major goals toward better understanding the manifestation of coronary artery disease in women. The first one is having a better understanding of the complexity of gender-specific symptoms. The second one is outlining appropriate non-invasive tests that can identify both patients with obstructive coronary artery disease and those with normal coronary arteries at increased risk of a cardiovascular event. And the last one is understanding the gender-specific pathophysiology of chest pain, ischemia, disability, and factors determining the progression from minimal atherosclerosis to ischemic event. In summary, according to the findings of this study, an understanding of the pathophysiology roles of microvascular dysfunction, subendocardial ischemia, inflammation, genetic predisposition, and neurohormonal imbalance can promote the early identification and treatment of patients at risk. This article presents the case of a 47-year-old man, smoker, known to have bronchial asthma, hypertension, and peptic ulcer, was admitted with a history of upper abdominal pain, mainly epigastric, associated with vomiting. Pain was moderate in intensity and sometimes radiating to both flanks, and was continuous for the last 3 to 4 hours with no chest pain or shortness of breath. On examination, the patient was conscious and alert. His blood pressure was 160 over 100 and heart rate was 100 with no discrepancies in pulses. There was mild epigastric tenderness, mild bilateral expiratory wheezing, and short systolic murmur along the left sternal edge. This patient was presented with dissection of the aorta, which relatively uncommon. Patients usually present with severe chest or abdominal pain and acute hemodynamic compromise. Diagnosis and management is crucial to reducing morbidity and mortality. The most important risk factor is hypertension, along with atherosclerosis. The detection of aortic dissection in this patient was challenging because the symptoms were similar to other health problems such as pancreatitis or perforated ulcer. Although suspected, several imaging studies was done to rule out aortic dissection. An echocardiogram indicated a bicuspid aortic valve with significant aortic regurgitation. Patient was referred to a vascular surgeon for further evaluation. The surgeon advised medical management and good control of his blood pressure. Patient improved within a few days without any complication. Aortic dissection is a medical emergency, and medical management remains the standard treatment. Sudden cardiac death is defined by the World Health Organization as death within 1 hour of symptom onset or within 24 hours of being observed alive and symptom-free. Despite effort in prevention and treatment, sudden cardiac death affects 3 million people annually worldwide and affects approximately 1 in 1,000 people each year in the U.S. Several studies, including Mendelian inheritance, candidate genes analysis, and genome-wide association, have helped our understanding of the genetics of sudden cardiac death. Study shows 50% of sudden cardiac death cases were identified to have inherited cardiac disease on postmortem genetic testing. Although sudden cardiac death can develop in a person with pre-existing heart condition, after validating the phenotype in the deceased and identifying the underlying mutation, genetic screening should be performed in all family members. Understanding the pathophysiology of inherited cardiac disease is important as they predispose people to sudden cardiac death. This article discusses how genetic testing can be used to identify patients at risk of sudden cardiac death. Genetic testing for cardiac chylomyopathies and cardiomyopathies is a possible useful tool for clinicians if used appropriately. Chylomyopathies is defined as a group of disorders caused by defective ion channel. They may be either congenital or acquired. Cardiomyopathy, on the other hand, is a disease of the heart muscle. It can be inherited and affect several members of a family. Review of these two cardiac disorders has led to a better understanding of their genetic basis. Genetic testing for both channelopathies and cardiomyopathies can be helpful in identifying carriers, guiding therapy, and assessing prognostics.